The second is the emotional and psychological benefits. And I think this is what Mark talked about in the catharsis. It's really important on a couple points. For the injured party or the injured family, it really restores some of their psychological injuries in the sense we would have say, why me? Why this bad thing happen to me? If it's not explained, there isn't any healing for me as to what happened. So that's a part where we can help the families. It also gives those families empowerment, or that person empowerment. They have a way to help correct what happened to them. For you, as the providers, what can it provide to you? Mark talked about it, but it provides your personal integrity, allowing you to stand up and say, I made a mistake, and here's what I'm going to do to help fix this mistake going forward. Mark talked about it, forgiveness. I think that's really important for all of us. You have very, very difficult jobs, and if you make a mistake, if you can be forgiven, I think that really helps you move forward and be less concerned about doing the right thing the next time. And the most important also, just personal integrity, that you have a personal integrity that I did the right thing. And then in my world, when I try a case before a jury, I analogize that Mark and I are putting on plays. He's putting on one play, I'm putting on a different play with the same facts, and I'm trying to convince a jury that my play, my story, is better than Mark's story, and they should believe what I'm saying and what my client is saying. And when I have this process occurring, if I'm in a courtroom, I can stand up and say, Dr. Jones has told you she made a mistake here. And she told the family she made a mistake here. And the issue we're trying to find out is what is fair for the compensation of this family or for this resident because of the mistake that the doctor made. When I'm able to make that argument, it diffuses the anger within the jury, and it really focuses them on what happened here and why, and they can really focus on that rather than being mad at the arrogant doctor or the arrogant nurse or the care provider who just didn't care. And I think it also allows me to really give an honest explanation of what happened. I'm not trying to shift or hide the ball. So things to me, those are some of the reasons of the why of the apology. And now we kind of like to talk about the when to say I'm sorry, the second point. Mark talked about it a little bit, but it just, when you have results that differ from what was anticipated, from the treatment or the procedure, in other words, you had a mistake or an error. Another way to look at it is you had a diagnostic test, a surgical intervention. It was supposed to go one way, it didn't go another way. So that's an adverse event. You also have to look at, so you have the error plus the adverse event. In my view, that gives you that opportunity to apologize and put in process the process to go through the system of apologies. This isn't clear cut, it's not black and white. There's some real significant ethical considerations for you personally and for your organization. Which errors do we report? We could take a position, we're going to report all errors. Well, does that make sense? Not all errors are legal consequences, so that would be a decision you have to look at. What happens if there's an error but there's no harm? Should we report that out of the integrity of our system? Across the board, we're just going to report. That's our process. Or what happens if you say, well, it's an error that's not going to be discovered? Example, the University of Michigan case. That medical director had information, didn't get the details, that he said wouldn't have been in the chart, that wouldn't have been needed to have been disclosed. They chose they wanted to disclose those. Not saying there's an easy answer, but those are questions as you go if you want to get engaged in this process, you have to decide for yourself, which errors do you want to set in place for your process? Kind of goes for the same thing, which patients, which residents. Do we do it on all? Only those who raise questions. Same thing, only if you figure out that if somebody reviews the chart, boy, they might find we made an error here. Those are your decisions you're going to have to go through before you start the actual process we'll talk about next. So, what are the risks of the apology? There are many. Obviously, disciplinary action. You're all licensed. You can have reports to the Board of Nursing. You can have internal disciplinary actions within your organization. A malpractice claim that Mark's talked about. Potentially, unfortunately, criminal activity, depending on the nature of the error. You have your reputation, your loss of clients, and then your loss of self-confidence. Those are all risks of doing it, which have to counterbalance about, should I do this system or not? In my view, the first three of those, disciplinary action, malpractice claim, criminal action, if the error is bad enough, whether you apologize or not, that risk is going to be there. So, to me, that's just something that can come because of the nature of that. The other part, I think, is by going through this process for the loss of clients. If you have a reputation of you're a stand-up person, when you make an error, you communicate it, you explain what happened, and you help your client move forward, I think your clients, we're going to recognize that, and you won't lose that loss of clients or your reputation. And to me, the biggest point for each of you in this room is that loss of self-confidence. That if sometimes you say, I made an error, no one knew about it though. It's okay. No one found out. It's in your back of your own mind and you're self-doubting yourself. You're in that next circumstance and you haven't personally moved forward. I think that puts you in a real difficult kind of emotional perspective. So I think from a loss of confidence, this process can rebuild that confidence for you. So now we'll move to the third area of the how to apologize. So as you talked about, we have an adverse event or an unanticipated outcome, kind of three main areas. Your disclosure program goes into action, and that is where the family or the resident or the patient are approached, and the initial event is disclosed in the apology. Mark had the three circles. To me, what this process is, and we'll go through the details, is that you have a very structured process in place. And we'll talk about how some of these people do it, but that there is a system of to whom is the error reported, who has responsibility for initiating the contact with the family. Those people who are in those first roles have to be trained very well because that first communication to the family is very important in setting the tone, and it needs to be someone who's skilled or has training in how to approach it. And some of the things you need to find out, it sounds simple, is contact information. But who's the point person? And you're in the hospital setting, mom has an adverse event, the 6 children in my family all are A-type personalities. We want to be in charge. So you're going to talk to 6 of us. No, you're not. You're going to talk to 1 of us. You're going to make sure that you say, from our operation, you're going to talk with Nurse Jones. She's going to be your point person. And we would say, oh, good, you're going to talk to Steve. And Steve will communicate out to the family. There's one point of communication. Very important so that the communication flows well. And you're there to help. These people are in need. Think if you have someone from rural Minnesota, they come to you, University of Minnesota, it's supposed to be a routine surgery, 2 or 3 days later, dad's supposed to come home. Now they're told dad's not coming home for a month, 6 weeks. How's that family going to cope? How can you help them? How do you get them set up in hotels, phone calls, spaced within your facilities? How do you make it so that they can deal with that adverse event and they're feeling, boy, this hospital, this clinic is there to help me? And then what do you say? What you say is, however it comes out of you naturally, but heartfelt. We are sorry for what happened. We're going through a thorough investigation right now, and as we learn things, so will you. But understand, there's a number of people we have to talk to. Some of our nurses are on different shifts. There are a number of pieces of information or paper we have to gather. This may take us 3-4 days before we can even get back to you initially to tell you what's happening. And then it might take another week or 10 days after that for us to get lab reports back and to talk to other doctors so we can really tell you what happened. Let them have an understanding of the time frame that this is going to take for them to understand that you're not stalling, that you're not covering up, that you're trying to address their needs. Also, I think in the right case, I mean, obviously we have peer review, quality assurance that you want to keep in-house at times. But in significant cases, you may want to have someone outside your facility take a look at this. So you can say to the family, we had so-and-so from one of our colleagues, another hospital, look at this and give us their thoughts or her thoughts on this. It's important. I think the family says, hey, you didn't grade your own paper. You had somebody else look at it. I think it's especially important when you look at a circumstance and you think, I don't think we did anything wrong here, but we're going to dig into it. And if it's in that circumstance and you bring somebody outside your organization and they verify that, I think it's helpful to be able to say to the family, we just didn't do an internal. We had someone else look at it, and they agree with us. There was an error that occurred, but it wasn't a mistake. Accidents happen. And we don't feel, unfortunately, that there's anything that we did wrong here. There isn't any corrective action we need to take. Family may not be happy, but outside entity helps. Other thing it talked about is over that time period, really stay in contact with the family. So what are the steps? You've done your investigation now. You're ready to talk to family. It's going to be two options. Your investigation shows, for easy decision-making, that there was an error, and we'll talk about there was not an error. So once you've gathered that information, you set a meeting with, if you can, all the involved family members at this point. So it's not the communication where it's from one person and another sibling hears it differently. Try and get everyone on the same page. You then again go back in, a sincere apology for what happened. You admit there was that error. And then more importantly, what did we do while we talked to all the nurses involved? We looked at the lab reports. We've done all these things, and here's what we've found. And then what action have you taken? Well, if it was an error that required disciplinary action for a staff, I think you can say that this was reviewed and appropriate action has been taken with the staff. You don't have to say what. If a staff was terminated, you don't have to say the staff was terminated. Just say we've reviewed it and appropriate action has been taken with that. Or in my world, a lot of times they will do across-the-board training. So we have an error with a mechanical lift. They will then, within shortly 24 hours, retrain all of the staff. And I have the sign-in sheets for the staff. We'll present that to the family and say, yes, an error happened with the training. We've retrained every employee here who operates a mechanical lift so they know how to operate it properly. That addresses one of Mark's issues, that the family has a concern of how is this not going to happen again. And then at that time, if you're internally self-insured or if you have an insurance carrier, your insurance carrier will need to be on board with this process. But then you would talk to the family, what are their needs? Their needs might be money. Their needs might be, I had a client, none of us could explain why there was a hospital bed malfunction. All the experts, none of us figured out. What the family wanted besides money is they wanted quarterly PM or preventative maintenance reports on the beds to them on a quarterly basis for 3 years. They wanted to make sure that this issue wasn't repeating. We talked to the client and we provided that to them. That gave that family some closure. It gave them a feeling they were doing something that was helpful. So what happens at the investigation? Your conclusion, there isn't any error. There isn't any fault in us. Same process, but it's really important to be not defensive, but just very objective. Here's what we've done, here's what we've found, and here's why we don't believe our organization made any error. This is why we don't believe we need to change our practices or our policies. Probably the most important last message as you go out that door is to be able to say to that family, we want to have an open dialogue with you. We know you may not be happy with our conclusions here, but as you have other questions, as you have what ifs, call us, because we'll continue to look at that. Because when this family goes home, they talk to their neighbors and their friends, and the neighbors and friends, well, that's not right. It has to be this. You should ask them about this. Create that dialogue that you can continue to talk with the family, because that way they're going to you rather than going to Mark to get their answers. Mark talked a little about two of them. I just want to highlight it. So you have the Lexington VA hospital disclosure. So in that organization, the risk management, the communication all throws to the risk management department. They identify the adverse event, whether it's possible negligence. And then through that group, they have people who are trained and specialized in communicating with the family, and they start that process through. If some of you are interested in more of a template, Ashram has a disclosure model. You can go on to their website, and they have a very nice outline for you to follow. But it has 4 very key points we've talked about. One is preparation before you meet with the family, the initiation of the conversation with the family. We talk about the conclusion of the conversation with the family, so the family understands the process has been brought to an end from your perspective, but you're leaving it open for them. And probably the most important thing about this process would be the documentation. And that would begin at the beginning, so we know how to prepare a client's or a resident's chart and what documents need to go in there. But in this process, you really want to make sure that you've almost like a timeline of, on this date, Steve Plunkett communicated with Mark Kosieradzki about that there was an error. And then you document the conversations. You document what pieces of information were provided. It's a paper trail so that you have all that information. Now, for some of you, I know there are a few of you who are in the legal world, what you have arguably done is just made a paper trail that if you get sued from Mark, by Mark, you've just given him an outline of all of the things that you've done. There's a debate when I presented it to my fellow defense lawyers where they really disagree with my view here. And this is my bias, is that that type of case you're likely going to get sued on anyways. If it's a case of liability, often for me, I'm going to, when you're with a doctor, it's a little different circumstance because the doctors, you need their permission, often under their insurance policies, to admit liability. But in my nursing home world, I have a different world. What I would say to my director of nursing, within the first 30 seconds of that conversation, did you know that you'd either violated a standard of care or a policy procedure? If the answer is yes, by the time that case gets on my desk, I'm not fighting that issue with Mark. That's not where the case is battled about. The case maybe I'm battling medical causation, saying that error didn't cause this harm. Or the damages that the family or the individual thinks they have aren't what we believe they are. They're related to other things. We move on to other issues. So you may hear some people say, well, I can't believe Plunkett told you to go and document all this stuff. That's my bias. I think it's a better way to move through the system because, as Mark pointed out, not that many errors result in lawsuits. And hopefully through this process, you will remove some of the incentives for those families who are going to sue. And there are always going to be circumstances where you're going to get sued no matter what you do. So my bias, I want to kind of get it out there that there is a downside to doing this process. I think the organizations who have done it have decided for them it's a cost-benefit analysis. They've lowered the time that they have these cases for them. They've lowered the amount of money they pay to lawyers like me, and they've lowered the expense they pay out in the claim. So they've looked at it, they've decided it's better for them than not. So the last area I just want to cover is avoiding the false apology. And there are two examples here that I think were wonderful here. And you have it in your slides, but this one I thought nailed it. And I just want to read it to you because the words are really powerful. To his mother, father, younger brother, and other family members. Very personalized. We extend our prayers, thoughts, and deepest sympathies. That's really heartfelt. And this is the part that I think is critical. We take full responsibility. They owned it for Sebastian's death. It's not for Mrs. Jones' death. It's not for our patient or our client's death. It was for Sebastian's death. And are very, very sorry. I think this is just, to me, that's a wonderful communication that is very heartfelt, that a family's not saying, boy, some lawyer didn't write that. No, a person wrote that. Not that lawyers aren't people. Here's another local from Park Nicollet. And I think it's good, and I'll let you decide whether is it as good. But from my perspective, it has. We accept the full responsibility. We've apologized to the family. My view is it's a passive language. We've done this, rather than the active language. So just trying to give you a little example of how these types of wording can be important when you're communicating with them. And I thought there was a great quote from Gilbert Chesterton. He said, a stiff apology is a second insult. The injured party does not want to be compensated because he's been wrong. He wants to be healed because he's been hurt. And I think that's what these messages are saying to these families. So what are the four elements of a real apology? I'm sorry, sincerely said. Accepting responsibility, take ownership, own it. Explain, we made a mistake, we didn't follow our policy. Explain what happened, how you're going to fix it. Explain the actions that you have done or will be doing to fix it. Talk with the family about compensation if they need that. So hopefully in my presentation you come away with three main principles. that I really think this system can help you reduce resident or patient's injuries because you've empowered yourself, your staff, your employees to do the right thing. And I think when they do the right thing, fewer mistakes occur, so you don't have the mistakes in the first place. Second, you're addressing the needs of your patients, your care providers, your organization quickly and fairly, and compensating them when harm occurs. And then on the flip side, if you've done everything right, you've investigated, and you feel that you have done what your organization should properly do, in my world, we very aggressively defend those. And those are the cases that I see with Mark, that we spend sometimes 18 months with each other battling over issues in the case. But hopefully it's about what is the real meaningful part of the case. So in my closing, every one of you in this room can really make a big difference in your organization about how you want to handle mistakes. Some of you are in a position where you may be able to bring an idea of the power of apology back to your organization on an organizational level. Some of you can do it as an individual. Some of you can do it with the people you supervise informally about just empathy for families and caring for them and trying to put yourself in their shoes when you're communicating to them. So my goal for you is that your facilities, your clinics, your hospitals are the best place for patient care and a loving place for your employees to work. So I appreciate your time. Thank you.
Thank you, Steve. That was truly wonderful and powerful. And I want to point out to everyone the amazing job our graphic facilitators have done capturing this, Cass McLaughlin and Cheryl Kartz. So thank you for that work there. And so Dan Peschet, our executive director, often says at events like this, what, so what, now what? And so my question for all of you is now what? And this is a great opportunity to ask these gentlemen that question and ask yourselves and each other that question. Now what? How do we, this is so powerful, and what can we do? So, and what questions do you have in the back?
How quickly should the initial disclosure happen?
So the question was, how quickly should the initial disclosure happen? My view is you've got to give yourself enough time to understand what happened. And so I think if it's a big error, you can figure out pretty quickly what happened. But if it's something where it's not as clear, you want to basically say to the family, something happened, we don't know what yet, and we're going to try and get to it. But for example, I think University of Michigan, or Illinois, excuse me, theirs is 72 hours or less is what they've put in as their guidelines of trying to get to the family. I think it depends on the circumstance and, frankly, how badly did it go wrong, and how quickly can you identify that. And to me, it's getting to the family quickly, letting them know, and then telling them, we've got to do our homework to get back to you. And I think if you do that, they understand that process.
I agree with Steve. If you let it percolate too long, people start thinking, the mind starts going nuts. You don't, it's identifying the bad event at the beginning and saying, this is what we're going to do.
I have a question. So I've been paying attention to this and studying this for a long time, going back to children's with children wrath and then the adverse event reporting. And so I strongly believe in this approach. But one of the barriers that I've seen is the National Practitioners Data Bank. And physicians don't want to settle because then they end up in the bank and they know the odds of you picking your case are slim, and then the odds of winning the case are slim. So what, I mean, have you found any ways to change that mindset or thinking or overcome that barrier?
I'll speak for myself again, since I really work with skilled nursing and assisted living. I don't run into that because I'm not dealing where I'm having to deal with a physician. I know there are a couple of people in the room, just by the smiles that we've presented to before. That's a really difficult issue. To me, I don't represent hospitals, I don't represent clinics, that's my area, but it seems to me that really is an organizational-wide discussion of how do you want to deal with that process. It is very difficult. There's a large impediment of that. To me, long-term, it's education, that if you can educate the doctors as to why this process can work and why it's, in my view, the most humane way to do the process, that's the way you have to go at it. But you're right, it's very hard to get doctors to agree.
I'm not a fan of the data bank. I think what it does is it needs communication. It advocates for this win at all costs. Sometimes there are things that are gray areas that can go either way. It could be the patient loses or the doctor gets hit 10 times more than the assets he has available or she has available. Because not everything in life is black and white. But what it does is it breaks down the communication to solving the problems. And the problem is, my view of the data bank doesn't mean anything. But I wouldn't advocate it for the nursing homes. I deal with it in malpractice, and we've got to deal with all these kind of creative solutions, particularly when someone has done a serious mistake, feels bad about it, wants to deal with it, but because of all the powers around them, they can't. So it's not a good thing.
I actually like what you said about it's not black and white, because medical error is a big, long scale of, there's all kinds of medication errors that you catch before they get to the patient, and then there's all kinds of patient perception of errors that aren't necessarily errors. So when you're going to jump to apology and documentation, you have to be careful to listen first and kind of understand the whole picture, and then yes, you can acknowledge and you can say, I'm really sorry that that happened and let me look into it, but before you say, oh my God, we made this big mistake, I hear what you said and I don't know, that happens all the time or whatever, you jump into a liability that isn't necessarily your liability or never reached the patient. And so it is a very wide area, and you have to kind of pick where you're going to apologize and what you're going to apologize for. You can always apologize and say, we can look at that, but not say, oh my gosh, we made a mistake. It could be a mistake, but it could be a mistake that was mitigated and never reached the patient. Or they could be complaining about something that's not really a mistake per se.
One of the things I see is kind of the legitimacy of the process. And what you were talking about, some things are just bad things happen, some are really bad things. But you have to get all your facts before you make a decision. But now when you're reporting it, you better have something legitimate. For example, I have a case right now that's going to trial, and it's going to go to trial because it's become polarized. Woman comes into a nursing home. She can maneuver a little bit, but she's on a walker. Next morning, she's got a hip fracture, a very serious hip fracture that ultimately kills her. The nursing home comes in and says, we've done a full-scale investigation, we can't explain it. Well, number one, you better come, if someone comes up with a big hip fracture, you better come up with an explanation. That's not a little error. So they couldn't come up with any explanation, but they came to me. What did we find in the course of our work? In the investigation, we had reports all the way up till 10 o'clock at night that the patient could ambulate with assistance, and then at 7:30 in the morning they're giving her Percocet. And this super investigation didn't talk to anybody who provided care between 10 o'clock at night and 7:30 in the morning. So that's not a legitimate investigation. And so now everybody's pissed off, and it's almost impossible to resolve that. Where if they would have come at the beginning and said, we, number one, figured out everything, or say we've talked to everybody, nobody will explain it, you got something like a hip fracture that it just doesn't happen. And so you have to have a legit investigation.
So I think back to point, appreciate that.
Yeah.
First thing you can say is, I'm sorry,
Sure.
Period. You don't have to say, I'm sorry and we made a mistake. I'm sorry, we're going to try and find out what happened here.
Yep.
You do your investigation, and after the investigation, you can make that determination This, in your view, this was not an error, this was not a mistake, and you communicate that to the family. But you're right, we're presenting it as it's a very nice black and white process. You know in your world it isn't. There's a lot of gray. We're just trying to give a structure conceptually of how you can put this in place. But you're right, that's why the people who make that first communication need to be very trained and skilled to understand the words they are using and the messaging they're providing to the family at that time.
That's a really big deal. We just got involved with finished up a rape case. The administrator, just shut down and didn't want to confront, and that brought the person to my office. What helped for them is they had a pastor who came in and met with the family, literally, and met with the patient on and on and on, brought the heat down. And they came to me, but then they came back in, and when they brought the heat down, the case got resolved.
There's a question.
I want to go back to Steve's example when you said mom was sent to the hospital. That's supposed that happened Friday night. And then the family came in Monday morning asking the CNA and the LPN about what happened. Can you give some examples of a good response from those people who may have no idea what to say?
So let me make sure I understood it. So patient sent to the hospital on Friday.
Friday night.
And the investigation starts on Monday?
Well, family member came in to get some personal belongings on Monday, asking the CNA and the LPN what happened to mom. That's Steve's example.
Okay.
The response I would give is if you have this policy or this practice in place, the CNAs and the LPN, my two examples, they would know that. And if the family hadn't communicated already, or we hadn't communicated to the family, the CNA would say, well, thank you, you can talk to this person. They know there's a point person they go to, and that person then would be trained to respond to that question, saying, thank you, I didn't know about this, or I'm going to look into this for you and get back. It doesn't put the CNA or the LPN in a position where they're forced to respond. They have the tools to communicate and send the family to the right person.
But what's important there is if there was a real adverse event, you don't wait till the family's saying what's going on.